with the Michigan Department of Health and Human Services and the Bureau of HIV and STI. Syphilis is definitely a hot topic right now, so I am really happy to be here with you all today and having the opportunity to talk about syphilis and congenital syphilis. This afternoon, I will talk about our perinatal screening guidelines, data and trends being seen in Michigan, as well as some specific congenital syphilis case details from 2023 for our reported cases of CS. So again, thank you all for your time and attention today, and I will go ahead and get started. So starting off, just as a reminder for everyone here, that Michigan enacted an updated package of perinatal testing laws in December of 2018. These laws did put us in accordance with the CDC guidelines, and the law states that pregnant people should be tested for HIV, hepatitis B, and syphilis at their initial prenatal care appointment. This typically and ideally really happens in the first or early second trimester. They are then to be retested for those same infections during the third trimester. The law also includes that if a patient is to be tested if they present for delivery without documentation of previous testing, and at any point if there is a declination for testing, a reason for the refusal must be documented in the medical record. MDHHS further recommends that the third trimester test be completed between 28 and 32 weeks gestation. And the reason for this is the treatment for CS needs to be initiated 30 days prior to delivery to be considered adequate. So that time frame really just allows for a better window of intervention before delivery. Another point that I want to just highlight in this law real quick is that first box. So the law states that the testing should be completed at the initial prenatal care visit. So the key word here definitely being initial. This visit does not always mean the first OB appointment. The initial visit can be and is often sometimes at emergency rooms or in urgent cares. So if you're seeing patients in these environments who are pregnant and they do not have these labs in their chart already for the pregnancy, you are the initial visit and these tests should be ordered. So now let's get into some of what's trending here in Michigan with syphilis and congenital syphilis. This slide here illustrates the trends in primary and secondary syphilis among male and female cases. Over the past decade, there has been a noticeable shift in syphilis rates within the female population. Initially, the rates remained relatively stable for several years, but in 2017, a noticeable increase began. The line graph there on the top of the bars depicts the percentage of cases attributed to females. In the most recent data there from 2022, 21% of our primary and secondary cases were among women, many of which are of childbearing age. This graph here is showing rates again of primary and secondary syphilis categorized by sexuality. So similar to the previous slide, the rates remained relatively stable in 2017 until 2017, after which we observed that significant increase in transmission among the heterosexual community. The colors representing heterosexual males and females in the bars are shifting noticeably over those years. And then by 2022, nearly half of our primary and secondary cases were among individuals that identified as heterosexual. For many years, there was this persistent stereotype associating syphilis solely with MSM, or men who have sex with men. And unfortunately, that stereotype still persists today and really poses a dangerous misconception. Syphilis is no longer confined to the MSM population. There is still a disparity there in that demographic, but the data clearly demonstrates that syphilis transmission extends beyond it. And I also like to just note that these trends are not Michigan specific. They are being seen across the country. And, all of this matters because the more syphilis we have in the heterosexual community, the more congenital syphilis we'll have, right? More women with syphilis equals more babies exposed to syphilis. So this slide also, again, represents rates of primary and secondary syphilis. But the map here on the left depicts data from 2012, where the main concentration of cases is evident in southeastern Michigan. Additionally, there was some slightly darker shaded areas in Kalamazoo, and a small cluster in the northern lower peninsula, or the tip of the pinky, if you will, looking at the map. And then you fast forward to the right side, and that is 2021. And here we witness this stark transformation. Cases do remain heavily concentrated in Southeast Michigan, particularly in the Metro Detroit area, which does bear the highest disease burden for the state. But notably now we have higher rates that are observed in Kalamazoo, with Kent County emerging as another hotspot, trailing behind Detroit. And then furthermore, the spread has extended to several other counties in the surrounding areas and in northern Michigan. And it has now made its way into the Upper Peninsula as well. And I know this data is a couple years old, but it really just provides a valuable visual representation of how the situation has evolved. And these trends from 2021 have only continued to exacerbate, right? So that's just continuing, in the wrong direction, if you will. And then historically, the city of Detroit has held the highest disease burden in the state. And that continues to be so. We do see a majority of our cases coming from within the city of Detroit. This graph here is illustrating incidence of congenital syphilis spanning approximately 3 decades or so. And then notably, you'll see there was that significant surge of cases in the early 1990s. So during this time here in Michigan, we were in the midst of a syphilis outbreak. We were actually, our state here, we emerged as a focal point for infectious syphilis cases during that time. This spike in cases was largely thought to be attributed to the prevalence of crack cocaine use that was happening during that time frame. You can see cases then dropping down as low as only 4 cases there in 2009, kind of remaining steady, and then kind of slowly starting to see this increase again over the last few years. From 2017 to 2021, there was over 300% increases during that time. We did have a slight little decrease there from 2021 to 2022, which we were all kind of cautiously optimistic about that. But we will look at 2023 a little bit more closely, but we did have an increase in cases for 2023. So here's another map of Michigan, and this map is showing cases of syphilis in pregnant people across the state from 2019 to 2023. So during this time period, majority of the cases were being seen in Wayne, Oakland, Macomb, Genesee, Kent, and Kalamazoo counties. But you can really, see there that the entire Thumb region saw at least a case in every county. A majority of the west side of the state was having reported cases of syphilis in women. And the northern Michigan and the UP are continuing to see more cases, although it is less common in that area of the state. I did report last year our first case in the UP over, not really sure how long, but a very long time, at least since I've been there, up in that Jobbik County right there on the Wisconsin border. On this graph here, the blue bars are representing the number of pregnant people with syphilis, and the orange bars are the number of reported congenital syphilis cases. Overall, I think we do a pretty good job of averting cases of CS. Just looking at the last 3 years, on average, we averted over 60% of congenital syphilis cases. So really meaning that we were able to get the pregnant person adequately treated there before delivery. So overall, I think, our DIS work really hard, and I think they do a really good job of getting these clients treated before baby's born. And we are going to look into why those remaining number of cases resulted in the reportable cases in a few slides. when we look at the breakdown of our 2023 cases of CS. So next I want to take a closer look at what we saw here in our reported cases for 2023. Our cases last year exhibited almost a 60-40 split between Black and white women. The ages of mothers ranged from 19 to 39, with the majority falling between 20 to 29 years old, which comprised about 70% of cases. Most of the cases were staged as late latent or unknown duration with 35 individuals. 19 cases were primary, secondary, or early latent stages. So these are the stages that are infectious to partners and that have typically been acquired within a year. Additionally, 7 cases showed signs of reinfection during pregnancy, as evidenced by a 4-fold or higher titer increase in the pregnancy. So I know we looked at a geographic distribution of primary, secondary cases on that map a few slides ago, but this here is laying out where we reported cases of CS last year. So you can, so if you look, you consider, I guess, more like northeastern-ish of the Detroit area, we reported 24% of our cases. So that included cases coming out of Oakland, Macomb, Genesee, Ingham, Shiawassee, and Sanilac counties. Going now more to the western side of the state, we reported 33% of our cases, and those were coming out of Kent, Kalamazoo, Wayne, Calhoun, Van Buren, and Washtenaw counties. I know I mentioned earlier, but the Upper Peninsula saw its first reported case there in many years, up in Jigobit County, close to the Wisconsin border. The remainder of the cases, of about 40%, were located within the city of Detroit. This is down slightly from previous years, but Detroit has historically and continues to hold the majority of our CS cases. One of the most significant barriers we encounter in reported cases is the absence of prenatal care. Last year, about 69% of our cases had late, limited, or no prenatal care throughout their pregnancy. These cases present really minimal opportunities for follow-up, additional testing, or treatment, rendering them really what feels like impossible to avert those cases. On the other hand, the remaining 36% of our cases received consistent prenatal care throughout the pregnancy, and these cases typically do undergo testing as required by law. However, they are reported for various reasons, such as reinfection without or with inadequate treatment before delivery, maternal treatment being less than 30 days prior to delivery. We did have some cases where the pregnant person was non-reactive, had non-reactive test results throughout the pregnancy. So first or early pregnancy and then third trimester were non-reactive, only to be found positive at delivery. And then additionally, we had a couple instances where the infants exhibited signs or symptoms of congenital syphilis at birth that required those to be reported cases. So this here is a list of case findings from our reported cases. As I stated earlier, actually, I don't think I actually mentioned it. I'm reading my notes here, and I don't think I did mention that we, for last year, had 4 stillbirths and 1 infant death for 2023. 31% of our cases had co-infections of HIV, hepatitis C, or other STIs during the pregnancy. Almost a third of the infants born to women with syphilis were low birth weight, and over 40% were born premature. Both of these things could certainly be a result of the syphilis exposure, but could also be contributed to by other factors in the pregnancy. 33% of the reported infants exhibited signs or symptoms of CS upon exam or evaluation. So this could include abnormal CSF labs, evidence of long bone involvement on X-ray, or snuffles. I looked at my case count earlier before this presentation, I will just like to note for everyone that I have reported 16 cases of congenital syphilis so far for 2024, and that does include 2 stillbirths. So we're almost to April here, and we're, and I do have a couple in process. So before April here, I think it's likely we're going to have about 20 cases of congenital syphilis for the first part of the year. So it's not looking great so far for CS this year for us. We frequently encounter various barriers that contribute to this lack of prenatal care. So a few that I wanted to highlight here are substance abuse. Especially here, we see reports of IV drug use, crack cocaine use. Occasionally, some methamphetamine use has also been reported among our clients. Unfortunately, right, individuals who are grappling with substance use often avoid seeking care due to fears of involvement with child protective services. Additionally, transportation challenges, mental health barriers, and housing insecurity are frequently cited in our maternal interviews as hindrances to accessing prenatal care. Furthermore, we had some reports of domestic violence, which again just further complicates the ability to engage with healthcare services. So addressing these multifaceted barriers requires a comprehensive approach that includes not only medical intervention, but also support services and community resources to ensure optimal maternal and fetal health outcomes. So that is all that I had for you all today. If you do have any questions, there is a Q&A section where you can put those questions in, and we will have time to go over those at the end. My contact information is listed here. I can also go ahead and put that in the chat for anyone. So again, if you have questions, go ahead and put those in the Q&A, and we will get to those at the end of the presentation. So I will go ahead. I'm going to stop sharing my screen.
Thank you so much, Aaliyah. That was a wonderful presentation. Really appreciate that. We're going to transition over to Dr. Zucker, who's going to present on the clinical aspects. And Dr. Zucker is an assistant professor of medicine at the Columbia University Irving Medical Center and the assistant medical director of the New York City STD Prevention Training Center. He is trained in adult and pediatric infectious diseases and has extensive experience providing sexual health care to patients of all ages, as well as providing technical assistance and training around sexual health to clinicians. Thank you so much, Dr. Zucker, for presenting today.
Thank you so much for having me. And Aaliyah, that was both fantastic and a little disturbing with how many cases you've seen so far this year. So it's clear that this is not something that's going away, which is why it's so important that so many people came out today to hear us talk about it and think about what they can do to help prevent it. So as Gowrie said during the introduction, I'm an adult and pediatric infectious disease doctor. And that means I get to do a lot of consults on both mothers, fathers, and their children, sometimes all at the same time. And that's really important because, one of the things we need to do if we want to be able to eliminate congenital syphilis is realize that managing congenital syphilis really is a family affair. I have no disclosures. So the goals for today is we're going to talk a little bit about syphilis history, microbiology, and recent epidemiology. We'll talk about the screening recommendations for syphilis and pregnancy, and we'll identify the clinical picture and treatment recommendations of congenital syphilis. So why do we care so much about congenital syphilis? Well, there are a lot of reasons, but it's the fact that syphilis can infect the placenta through transplacental infection and therefore affect the babies. Transplacental transmission of the fetus can occur as early as the 9th or 10th weeks of gestation, but can occur at any point after that. Fetal abnormalities end up resulting from the robust inflammatory response, and therefore we really don't see them until after 20 weeks, even if they're infected before that. And that's because the fetal immunologic response is poorly developed in the first half of pregnancy. This can really have devastating outcomes on the fetus, including congenital infection. And it's actually recommended that any woman who delivers a stillborn after 20 weeks be tested for syphilis, as this is one of the potential causes. And the risk of infection to the neonate is related to a couple of factors. So what increases our risk of congenital syphilis? Well, the first is the stage of syphilis, with earlier stages being higher risk than later. The second is maternal infection later in pregnancy, being higher risk than earlier. And finally, what I'll highlight a lot today, and what Aaliyah really highlighted nicely in her presentation, the failure to adequately test and treat maternal infection leads to increased risk. So the diagnosis of congenital syphilis can be difficult. Maternal non-treponemal and treponemal antibodies can be transferred through the placenta to the fetus, really complicating the interpretation of serologic testing. The decision to evaluate and treat is really based on 4 steps. 1, identification of syphilis in the mother. 2, determination if maternal treatment was adequate. 3, look for presence of clinical, lab, or radiographic evidence of syphilis in the neonate. And 4, comparing maternal and neonatal non-treponemal serologic titers. And so now that you realize what we have to do, I'm going to introduce you to 3 patients. These are all based on real patients. However, we've changed some details to protect their privacy. I'm also going to take off these headphones because I'm finding them incredibly distracting. All right. Here we go. So the first patient is Jen. She's a 34-year-old bisexual female, pregnant with her first child. Her partner of 10 years is a 36-year-old bisexual man. They're in a committed, open relationship where they both have same-sex partners. She presents for prenatal care at about 10 weeks gestation. Next is Eve. She's a 29-year-old female pregnant with her first child. She described the baby's father to me as a fling, and he says that he doesn't intend to be involved, and she's okay with that. She presents for prenatal care at about 12 weeks gestation. Finally, meet Alex, a 24-year-old female pregnant with her first child. She's pregnant with her high school sweetheart, and neither of them has had any other sexual partners. So the first question is, who should be screened for syphilis? And I think Aaliyah did a great job introducing the fact that they should all be screened for syphilis. Like other infectious diseases and like any infectious disease outbreak, if we want to reverse the increasing numbers we're seeing, we need to test and treat more people. These are the current CDC recommendations for syphilis for screening. And for pregnant women, they recommend first prenatal encounter plus 3rd trimester and at delivery of high risk or endemic areas. And I think Aaliyah pointed out that in Michigan now they're encouraging 3rd trimester testing as well. The other thing I'd like to point out is this is not just about testing pregnant women, as many people will actually acquire syphilis before they're pregnant. We just make the diagnosis during pregnancy. And the one thing I do want to highlight is that if we're screening for sexually transmitted infections, we really should be screening for syphilis if we ever want to reverse the trends that we're seeing in both syphilis and congenital syphilis overall. So as a reminder, we should be doing complete STI testing on all of our pregnant patients. And while that was done here, I cut out the additional tests in the interest of time. But please assume that they all received comprehensive testing and any additional tests were negative. In our case, our first patient, Jen, had a reactive RPR with a titer of 1 to 1. Our second patient, Eve, had a reactive titer 1 to 8. And our third patient, Alex, had a reactive RPR with a titer of 1 to 1. So with our test results back, what else do we need to know to properly evaluate our patients and their neonates, or children? So as I said before, the first step is to identify syphilis in the mother. And to do that, we need to do testing. The tests used for diagnosing syphilis are the same in both pregnant and non-pregnant women. There are 2 types of tests, the non-treponemal quantitative tests and the treponemal qualitative tests. The diagnosis and interpretation of these tests is the same in both pregnant and non-pregnant women. I can probably spend at least an hour talking just about syphilis testing, but in the interest of time, I'm just going to briefly remind you that there are 2 different algorithms. I also want to remind you that syphilis testing is only relevant for people who don't have clinical signs and symptoms of syphilis. If patients have a painless chancre or have signs of secondary syphilis, then they likely have syphilis regardless of what testing shows. Testing is most important for people who have asymptomatic or latent syphilis. And if we want to reverse the trends we're seeing in syphilis, we need to screen and screen often. This is the traditional algorithm that starts with a non-treponemal test. There we go. Starts with a non-treponemal test, and if positive, uses a direct treponemal test for confirmatory testing. As a reminder, a positive confirmatory test shows evidence of syphilis infection, but this could be evidence of a current infection or prior treated infection, making interpreting titers critical for that distinction. And we'll talk about how to do that in a little bit, but it does remind us that history is still important and that syphilis testing is not a simple yes or no answer. The second algorithm is the reverse algorithm, which starts with a direct treponemal test, either an EIA or a CIA. Then if positive, reflexes to the quantitative non-treponemal test. And if those results differ, you perform a second direct treponemal test to break the tie. Again, while I'm not going through the complete algorithms today, I am happy to take questions about them at the end if there are any questions. But what is important is that using these algorithms, you can interpret the titers about whether patients have a new or previously treated infection. In addition to serologic testing, there can be other signs of congenital syphilis. Fetal infection may be suspected if there are characteristic non-specific findings on ultrasound after that 20-week point of gestation. Again, this is 20 weeks is sort of our cutoff, because around 18 to 20 weeks, you see fetal immunologic maturity, and you need that to see the signs. Some of the non-specific findings include hepatomegaly, placentomegaly, and things like anemia, polyhydramnios, and ascites all occur later in the course of infection. It's important to note that an abnormal ultrasound is not diagnostic of fetal infection, and a normal ultrasound does not exclude fetal infection. Now returning to Alex, who you may remember as having a baby with her high school partner. Neither of them has had any other partners, and they're really convinced this had to be a false positive test. And they're right. Her RPR was positive, but confirmatory treponemal testing was negative, making this likely a false positive. Some things to know are that false positives are more common in pregnancy. A positive low titer non-treponemal test can be considered a transient false positive due to pregnancy if the confirmatory test is negative, the patient is asymptomatic, and their history does not put them at elevated risk for infection. Repeating the RPR right now is probably not beneficial, as these can last for up to 6 months. However, all women with false positive pregnancies should have a follow-up after delivery. However, for Alex, what this means is that her baby does not need any further workup, but this is a surprisingly common question. So in Alex's case, we did not identify syphilis in the mother. However, what if mom had syphilis? Well, in that case, the next thing you need to know is whether maternal treatment was adequate. So how do we determine if maternal treatment was adequate? Well, we need to know about this. We need to be able to stage syphilis. So we need to know about the symptoms at the time of diagnosis. We need a history of prior testing, number and timing of any previous treatment given. And finally, we need to think about the chances of reinfection, including whether the patient's partner was treated, to fully assess for staging and how to adequately treat this mother for syphilis. So going back to our patient, so Eve, her RPR was 1 to 8 at the end of her first trimester, and confirmatory testing did return positive. We took a detailed history and found out that she'd never had any symptoms before, but had also never been tested for syphilis. So what stage is she and what treatment does she need? So again, understanding adequate treatment requires us to understand the proper staging of syphilis. And this is important. This diagram is from the New York City STD Prevention Training Center and New York City Department of Health syphilis monograph, and really highlights the stages of syphilis nicely. So it starts with the incubation period. After a recent exposure, you may not test positive and have no symptoms for up to 90 days. Therefore, for individuals who are sexual contacts of partners with known or suspected syphilis, we really should be thinking about presumptive treatment as opposed to waiting for a test and treat strategy. After incubation is primary syphilis. Primary syphilis is defined by local symptoms. This is traditionally the painless chancre that we think of as typical for syphilis that generally occurs at the site of inoculation. So again, primary syphilis is local with 1 or more ulcers at the inoculation site. It is important to remember that these are painless, which means if they're not in an easily visible spot like the rectum, vagina, or oral cavity, they may not be noticed. And so many patients test positive without ever having seen a chancre. They're often associated with regional or bilateral lymphadenopathy, which may be an additional clue. This also highlights the importance of doing a complete physical exam in order to best stage syphilis. In general, even without treatment, primary syphilis generally resolves in 1 to 6 weeks. It's important to know that this is a highly infectious stage of syphilis. One thing I'd be remiss to not mention is that we are seeing more and more atypical cases of syphilis. I think it was Osler who said that if you know syphilis, you know medicine. And that then also refers to syphilis as the great imitator, because it can look like anything. So I do want to highlight the fact that, the classic presentation is this single painless ulcer or chancre at the site of infection, but that we are seeing more and more atypical presentations, particularly with multiple atypical or painful lesions at the site of infection. After primary syphilis is secondary syphilis, which includes disseminated symptoms. This is what we traditionally think of as the rashes on the palms and soles, but also includes other disseminated symptoms like generalized adenopathy, fevers, chills, fatigue, hepatitis, and other symptoms. It generally occurs 4 to 8 weeks after infection, resolves in 6 weeks, and is also highly infectious. This is a table from that same New York City PTC monograph that outlines some of the many potential manifestations of secondary syphilis. Finally, latent syphilis, which I did mention briefly earlier, but latent syphilis is by definition asymptomatic. Early latent syphilis is when it's possible to document non-reactive syphilis serology within the past year, or a history of symptoms of early syphilis within the past year. Otherwise, the disease is considered late latent or syphilis of unknown duration. And these designations are important because they determine adequate treatment for syphilis. And I'll say it one more time because this is a question we get all the time, but latent syphilis requires no exam findings of primary, secondary, tertiary syphilis. So after diagnosing and staging syphilis, we need to determine if maternal treatment was adequate. And all of what we discussed so far really plays into treatment for syphilis, which is determined by stage. Here we have the CDC recommended treatment and alternative options. For incubation or exposure, primary, secondary, and early latent syphilis, it's a single dose of benzazine penicillin G, or alternatively, 14 days of twice daily doxycycline. For late latent syphilis of unknown duration or tertiary non-neurosyphilis, it's benzazine penicillin G weekly for 3 weeks, or doxycycline for 28 days. And finally, for neuroocular or otic syphilis, it's IV penicillin for 10 to 14 days. I want to highlight that in pregnancy, the treatment is the same, but we don't use alternative regimens in pregnancy. For women with a history of penicillin allergy, they recommend desensitization and treatment with penicillin. And this is because non-penicillin regimens are either contraindicated in pregnancy, like doxycycline, lack sufficient data for efficacy like ceftriaxone, or do not cross the placental barrier completely like azithromycin, and therefore are not recommended for pregnant women. Otherwise, treatment looks just like that for non-pregnant patients, with benzazine penicillin G injections for those once for those with early syphilis or early latent, 3 doses for those with late latent or unknown duration, and IV for those with neuroocular or otic syphilis. However, I will say that there is one difference to be aware of, and the CDC recommends considering additional therapy for women who have primary, secondary, and early latent syphilis with a second dose of benzazine penicillin G 1 week after the initial dose. I'll be honest, this is based on PK/PD data that shows altered penicillin levels in pregnant women, particularly in the later trimesters, with limited efficacy data and no randomized controlled trials. But I will say that for patients in their second or third trimester, I usually do recommend this additional dose. We frequently get a question about missed doses, so I wanted to cover that today as well. And it's that clinical experience suggests that 10 to 14 days between doses of Pen-G might be acceptable before restarting, although 7 to 9 is preferred, and that's for all patients. However, for pregnant women, in order to prevent congenital syphilis, we really do narrow that down. And we recommend that missed doses greater than 9 days are not acceptable for pregnant women. Pregnant women who miss a dose of therapy or greater than 9 days between doses should repeat the full course of therapy. And I want to highlight that we should be doing this even though right now that there is a benzosine penicillin G shortage from the manufacturer. I don't have it in these slides, but the CDC has actually recently allowed for extacillin to be shipped in from Europe, which is another form of benzosine penicillin G. And the goal is to preserve penicillin G for our pregnant patients as well as our neonates, since there are not alternative options for them. So going back to our patients to see if treatment was adequate. So based on what we just reviewed, Eve was diagnosed with latent syphilis of unknown duration since she had no prior testing, and she received penicillin G intramuscularly weekly for 3 weeks. In the case of Jen, her RPI returned reactive with a titer of 1:1 and a positive confirmatory test. However, when you obtain her prior records, Jen was actually diagnosed with early latent syphilis and treated 1 year ago with a titer of 1:64. She was treated at that time with 3 shots of penicillin G exactly 7 days apart. But does this positive test mean she needs to be treated again, or she's already fully treated? So for that, we need to understand treatment failure. Treatment failure is defined as a persistent recurrence of signs or symptoms and a sustained greater than 4-fold increase in non-treponemal testing for greater than 2 weeks. In primary secondary syphilis, a failure to see a 4-fold decrease after 12 months is failure. However, you should be aware that 10 to 20% of patients will not achieve this 4-fold decrease in titer within 12 months. And for patients with latent syphilis, failure to see a 4-fold decrease after 24 months. And this is actually most commonly seen in individuals with an initial titer of 1 to 8. So the thing is, we're talking about 12 to 24-month windows, meaning we really can't use our titer decrease to assess efficacy of treatment in our pregnant patients when we treat them. So while you may not see evidence of treatment failure, interpreting syphilis titers are important as they can show evidence of reinfection. Non-treponemal titers like our RPR are used to follow treatment response and look for evidence of reinfection. And quantitative testing involves the serial dilution of specimens to determine the amount of non-treponemal antibody present. A 4-fold increase in the non-treponemal titer is always abnormal. A 4-fold change is equivalent to a change of 2 dilutions, which is necessary to demonstrate a clinically significant difference between 2 tests. So for example, if you go from 1 to 16 to 1 to 32, that's a 1 dilution change or a 2-fold increase or decrease in titers and is not considered clinically significant. On the other hand, going from 1 to 8 to 1 to 32, or 1 to 32 to 1 to 8 is a 2 dilution change or a 4-fold increase or decrease in titers. Non-treponemal titers usually do decline after treatment and may become non-reactive with time. However, in many people, non-treponemal antibodies persist for a long period of time, a response referred to as the serofast reaction. So because Jen's titer had gone from 1 to 64 to 1 to 1, it reduced by more than 4-fold, or 2 dilutions, and she was considered adequately treated. Her titers are not consistent with a new infection, and she did not need any further treatment at this time. However, Jen returned at 32 weeks. She was asymptomatic, but repeat screening labs were notable for a reactive RPR with a titer of 1 to 16. This represents a more than 4-fold increase and is consistent with a new infection. It also highlights the importance of ongoing testing during pregnancy, since she was either in the incubation period earlier or when infected with or a new infection late in her pregnancy. She was given 1 dose of intramuscular Pen G for her early latent syphilis. And now that we hopefully understand syphilis in the mother, I want to talk a little bit about babies. The Red Book is very clear that no newborn infant should be discharged from the hospital without determination of the mother's serologic status for syphilis. So we've already covered the mother in terms of identifying syphilis in the mother and adequacy of maternal treatment, but the next steps focus on the babies themselves. The pathophysiology of congenital syphilis is kind of fascinating. At the onset, spirochetes are freed directly into circulation to the fetus, and they can disseminate to almost all organs. And then the clinical manifestations we see come from the inflammatory response. Since they can affect any organ, they can actually be very widespread and varied. The first step is to look for clinical symptoms of early congenital syphilis in the newborn. Hepatomegaly occurs in almost all infants with congenital syphilis and is associated with jaundice and cholestasis, as well as elevated liver enzymes. Syphilitic rhinitis or snuffles usually develops during the first week of life. It's more severe and persistent than the nasal discharge of the common cold. And the nasal discharge actually contains spirochetes, which makes it very contagious. The bold ones here actually contain spirochetes that can be infectious and do require contact precautions. An examination to look for signs of congenital syphilis needs to be complete because it can affect virtually any organ. I also put some of these classic images from the CDC, including rhinitis with mucopurulent nasal discharge or snuffles, and the typical desquamating and maculopapular skin lesions. Hepatosplenomegaly and jaundice in an infant with congenital syphilis. An X-ray of bony abnormalities, including syphilitic metaphysis, and an infant with diminished density at the end of the shaft and destruction of the proximal right tibia. And there are many more symptoms that I'm not going to go into today. But again, this is a page from the syphilis monograph that shows just the wide range of mucocutaneous, skeletal, CNS, hematological, GI, and other symptoms that can occur in congenital syphilis. But you don't necessarily have to have symptoms of congenital syphilis to have congenital syphilis. This slide shows the proportion of individuals with congenital syphilis who are alive without documented signs and symptoms, which is the largest dark green area. There's alive with some signs and symptoms, which is the lighter green area, and infant deaths and stillbirths, which are the blue area. In addition to clinical signs and symptoms, you also have to look for lab signs of congenital syphilis. These can be subtle findings like anemia, thrombocytopenia, leukopenia, leukocytosis, CSF abnormalities, or reactive CSF BDRL. And finally, radiographic findings like periostitis, metaphyseal serration, and destruction of the upper medial tibia, which can all be diagnostic for congenital syphilis. The final piece of information you need to put this puzzle together are a comparison of maternal and neonatal non-treponemal titers. This needs to be from neonatal serum and not cord blood due to the risk of contamination from maternal blood in the cord blood. And the goal is to compare maternal titers and neonatal titers with a focus on whether the infant titer is fourfold higher than the mother's. And so now that we've reviewed all the workup for babies, what will each of these babies need after birth? Jen had a new syphilis infection during pregnancy. She was treated with penicillin at 32 weeks. However, her baby was born prematurely at 34 weeks via C-section due to fetal distress. The baby's exam at birth was normal. Eve was diagnosed with latent syphilis of unknown duration, treated with penicillin weekly for 3 weeks, starting at 12 weeks, retested at 28 weeks. At that time, her titer was down to 1:1, and her baby was born at 38 weeks gestation via normal spontaneous vaginal delivery with a normal exam. Finally, Alex, as she had a positive RPR and negative TPA, she was diagnosed as a false positive RPR, and her baby was born at 40 weeks via C-section for failure to progress with a normal exam. So now we want to put this all together. And putting it together, there are really 4 potential scenarios: proven or probable congenital syphilis, possible congenital syphilis, less likely congenital syphilis, or unlikely. And these scenarios will help us decide what further evaluation and treatment is necessary for the baby. I think that proven or highly probable is the easiest criteria to talk about. In this case, a mother who tested positive during pregnancy, if the baby has an abnormal physical exam that's consistent with congenital syphilis, a serum non-treponemal titer 4-fold higher than the maternal titer, or evidence of direct detection of treponema pallidum, the baby has proven or highly probable congenital syphilis. And because it's proven or highly probable, the workup is extensive. This includes a CSF analysis with cell count protein VDRL, CBC, and a variety of other clinically tests that's clinically indicated, including long bone X-rays, chest radiographs, liver function tests, neuroimaging, and optho and hearing tests. In practice, we frequently do a lot of this workup for patients with proven or highly probable congenital syphilis. In terms of treatment, The general treatment is IV penicillin G, 50,000 units per kilogram per dose IV, every 12 hours in the first 7 days of life and every 8 hours thereafter, for a total of 10 days of therapy. Because this is proven or probable treatment, the entire course should be with penicillin, and if more than 1 day of therapy is missed, the entire course should be restarted. And an alternative therapy that you may see in the guidelines, but I won't keep mentioning, is procaine penicillin IM daily. While it was an option, one, it's not ideal to do intramuscular injections every day for 10 days, but actually more recently, this has been discontinued by the manufacturer, and so will not be an option moving forward. So that's proven or probable. Our second scenario is possible and is a little bit more complicated. It starts with a mother testing positive during pregnancy. And in this case, the baby has a normal physical exam, a reassuring serum quantitative non-treponemal titer that's less than or equal to 4 times the maternal titer, and one of the following. Mom was not treated. Mom was inadequately treated. Mom has no documentation of having received treatment, or mom received treatment less than 4 weeks before delivery. In the possible category, the recommended workup includes CSF analysis, complete blood count, and long bone radiographs. In terms of treatment, the treatment is very similar to before, with IV penicillin for 10 days. However, in this case, there is a second option of Pen-G intramuscularly in a single dose. So how do you choose between these two? Because I would imagine most people would prefer single-dose penicillin. Well, you should choose 10 days of treatment if the workup is abnormal, the workup is uninterpretable, for example, the CSF is contaminated with blood, the workup is not performed, or there's uncertain follow-up. I'll also add that neonates born to mothers with untreated syphilis at the time of delivery remain at increased risk for congenital syphilis, and a complete IV course may be considered even if the evaluation is normal. If the evaluation is completely normal, then single-dose treatment is an option. So going back to our patient, Jen, the baby was born at 34 weeks gestation via C-section for fetal distress, but after birth only required stimulation with APGARs of 7 and 9. The baby was appropriate for gestational age and exam was unremarkable. The RPR titer was 1 to 2, or the baby's RPR titer was 1 to 2. Mom's was 1 to 8, down from 1 to 16 3 weeks ago when she was treated. However, given that mom was treated less than 4 weeks prior, even though treatment was appropriate for her stage and titers are coming down, this baby falls into the possible category. In this case, a workup was attempted, but was unsuccessful due to a bloody lumbar puncture, and the baby was treated with 10 days of IV penicillin therapy. I'll also note that the baby initially got 48 hours of AMP and Gent for a rule-out sepsis, followed by the complete 10-day course of IV penicillin. Given the risks of congenital syphilis, we don't count additional or other types of antibiotics. We only count the IV penicillin in the 10-day course. The third scenario is that of a normal physical exam. Serum quantitative non-treponemal titers are less than or equal to 4 times the maternal titer. And all of the following. Mom was treated during pregnancy and treatment was appropriate for the stage of infection. The treatment was administered greater than 4 weeks before delivery. And mom has no evidence of reinfection or relapse. In this case, no evaluation is recommended. And there are 2 treatment options. One is intramuscular penicillin G times 1, which in general is my preferred option. A second approach involves not treating the infant, but rather providing close serologic follow-up every 2 to 3 months. This is a more intensive approach, but is an option, especially for mothers who may be hesitant about giving an injection to their child. And that's what happened with Eve, whose baby was born healthy at 38 weeks gestation via normal spontaneous vaginal delivery. Excuse me. The baby's RPR was 1 to 1, and given that mom was adequately treated more than 4 weeks before delivery, we did not perform any further workup and gave the baby a single dose of intramuscular penicillin G. Finally, the last scenario, unlikely. And in this case, the baby has a normal physical exam and serum quantitative non-treponemal titer less than 4-fold the maternal titer, as well as the mom was treated before pregnancy, and the mother's non-treponemal serologic titer remained low and stable during pregnancy and delivery. This means that the mom was serofast and did not have infection during the course of her pregnancy. This is something we get called for a lot. And I did want to highlight it because mom does not have a new infection during pregnancy. In this case, no evaluation is recommended and no treatment is recommended. Neonates with reactive non-treponemal tests should be followed. They should get careful follow-up exams and serologic testing every 2 to 3 months until the test becomes non-reactive. In the case of patients not treated at birth, we're looking for them to be non-reactive by 6 months. And if it remains reactive, consider treatment. For patients treated at birth, it should be non-reactive by 12 months. And if reactive, consider an LP and 10-day course of IV penicillin. For neonates with a negative non-treponemal test at birth, whose mothers are seroreactive, they should be retested at 3 months to rule out the incubation period. For neonates with abnormal CSF, they do not need repeat lumbar puncture unless they exhibit persistent non-treponemal serologic tests at 6 to 12 months. And persistent non-treponemal titers should be managed in consultation with an expert. Now, that covers the most common scenarios of children in their first 30 days of life, but we actually haven't discussed everything. There is one other scenario that we sometimes, although less commonly, see. Occasionally, you may get a patient over 1 month of age to evaluate for congenital syphilis. These are generally infants and children who are found to have reactive tests when they're older than 1 month. And the first step is always separating out congenital syphilis from the potential of later acquired syphilis, which requires a careful review of the records, showing that congenital syphilis is possible. It is important to always consider the possibility of abuse in these cases. If congenital syphilis is possible, then an extensive evaluation should be completed, like we mentioned earlier. And the patient should be treated with IV penicillin for 10 days, or if the workup is completely normal, 3 doses of intramuscular penicillin G. The reason to do all this workup and treatment is that untreated infants, regardless of whether they have early manifestations, can develop late manifestations, which usually appear after 2 years of age and involve the central nervous system, bones and joints, teeth, eyes, and skin. And these late manifestations can be prevented by treatment of early infection. And just as a reminder, I'm from the New York City ST Prevention Training Center. We do have some online sexual health e-learning courses, including one about congenital syphilis, if you want to review anything we talked about today. And with that, I'll stop and we'll take any questions. And thank you guys so much for joining.
Thank you, Dr. Zucker and Aaliyah Phillips. We do have some questions. The first one should go to Aaliyah. For the pregnant clients that don't have treatment within 30 days from giving birth and are considered an automatic congenital syphilis case, do they have to have completed syphilis treatment 30 days prior to birth or starting treatment 30 days before birth?
Sorry, couldn't find my unmute button there. I think I feel comfortable answering this question, but I'll also ask Dr. Zucker if he wants to chime in if I'm not correct or yeah. But so the treatment has to be initiated 30 days prior to delivery, but that treatment also has to be adequate. So if you have a patient who needs 3 doses of penicillin, so if she's getting the first dose 7 days later, the second dose, another 7 days, the third dose. So you're at about 21 days there. So she needs another additional week of being pregnant before that baby's born. So now at that point, treatment was initiated at least 30 days prior. And so that baby had at least 30 days of treatment that was happening in utero. And same thing for a single dose. That single dose has to be given at least 30 days prior to the baby being born. So hopefully that made sense. I'll ask Dr. Zucker if he wants to expand or if I.
No, I think that's
Okay.
pretty accurate.
Okay.
You know, it's all about where you're classifying them in the sort of algorithm that we talked about, right? And so if you're not treated within 30 days, you can't fall into the less likely category. The best you can fall into is the possible category, or if you have signs or symptoms, the proven or probable category. So if you're not treated within 30 days, you're automatically at least classified as a possible congenital syphilis, and then you get the workup that's associated with that, which includes treatment and other things.
Thank you to you both. This next question goes to Aaliyah. At a local health department level, what should we do if we are working with an infant who was born with syphilis if they are already involved with medical care? Actually, this could go to Dr. Zucker too.
So all cases of, all reported syphilis labs are handled most at the state level. All children with positive results under the age of 2 are reported to me directly, and I do all the follow-up on those cases and get those reported. So if there's things that we're not seeing with the infants that are not happening, we have questions about treatment or testing or things like that, I usually follow up with those pediatricians if need be. So I don't think that there's really much work that you need to do there at the local level, since we are handling that at the state level. But I will also pass that over to if Dr. Zucker wants to add to that.
Sure. Yeah, I don't think I can comment too much about the local health department. If they're involved with medical care, then hopefully they're getting the workup we talked about today. But I do think it makes sense to make sure it's reported and just double check, I guess, with you to make sure you're aware of it already, particularly if it's coming from out of state or coming from another jurisdiction. That may just be something you want to be aware of so you can communicate with wherever they came from.
I will just add to that, thinking that there are certain health departments that kind of keep tabs on their congenital syphilis cases more so than others. So certainly if you ever have any questions or concerns or anything like that, when you're in MDSS, and if you see anything, you can please reach out to me and I'm happy to discuss that with you.
Thank you to you both. Yes, definitely at the state level, we appreciate our local health departments, and all help is certainly appreciated. Next question for Aaliyah. For the 32% of cases that are receiving normal prenatal care in Michigan, what percentage of that do you think is inadequate treatment, reinfection, or automatic CS cases, i.e. not completing treatment within 30 days of birth or testing positive for syphilis at birth? What are other contributing factors to CS cases that are receiving normal prenatal care? There's a lot. I can break that down for you if you want.
No, I actually pulled it up too, because I was like, okay, there's a lot happening here. But actually, I do have, I've looked at this closely and reported this out to our leadership, so I can break this down totally for you. So for the cases that were considered normal prenatal care, there was 19 cases that were considered normal care. Of those cases, of that 19, the reasons we have 5 reasons that those cases were reported. We had 5 cases that were reported because the treatment was less than 30 days prior to delivery. We had 3 cases that were found positive at delivery. 5 cases that had a 4-fold titer increase at delivery. We had 3 cases that met infant criteria. So for those 3 cases, we had 2 infants that had a positive CSF BDRL, and we had 1 infant that their titer was 4-fold higher than the mother. So that was criteria for infant reporting. And then the last 3 cases, I kind of qualify or put them into is it cooperation issues, if you will. So these were cases that there was issues either on the client end or the provider end, mostly around treatment. So there was some debate among the provider and us here at the state health department about staging for mom and what the appropriate treatment for her was. Provider saying, well, I think she's an early latent case, and we're saying no, she is a late latent, and so treatment so essentially it is kind of inadequate treatment. But because of issues on either the provider not following treatment, or we have the client who needed 3 doses but continues to not show up for the 2nd or 3rd or restart her treatment, things of that nature. So that is the reason why those 19 cases that were in normal care were reported cases.
Thank you, Aaliyah. This next one goes to Dr. Zucker. Can we assume women in the serofast state don't transmit syphilis and thus don't need treatment?
So I want to clarify or make sure we're clear on the difference between serofast and latent syphilis. Serofast implies that they are entirely treated, they don't have syphilis anymore, and they just continue to have a low-level antibody that's produced, so the RPR will be positive, but they've demonstrated that fourfold decrease and they no longer have syphilis. That is different than latent syphilis, which is where you don't have symptoms, but you still potentially are infected and still have the potential to transmit to the fetus. And so it's very important that we make that distinction, and we're able to document adequate treatment with a fourfold decrease in titers if patients have been treated before pregnancy to ensure that what they have is truly serofast and not just latent syphilis.
Thank you, Dr. Zucker. This next question goes to Aaliyah. Does the Michigan data include women who are low titers, like a 1-to-1, or who are screen positive, RPR negative?
Aaliyah, you're muted if you're talking.
Yes. Good catch.
Yeah, thank you. Yeah, because I was muted and just continuing to talk. So all the slides that I shared with you today were rates of primary and secondary syphilis. So these are cases that had to qualify as one of those. So if they had a documented signs or symptoms, right, that are class B, so we're able to classify them as primary or secondary. So titer can range in those stages. I think I just answered your question. I don't know, Karen, too. I know you might have further input on that, but I did not get into, it was only rates of primary and secondary.
That's true, but in terms of your congenital syphilis cases,
Right.
those are cases that are a treponemal test positive.
Yes. Yes,
So
thank you.
regardless if it's a low titer treponemal test positive or non-reactive RPR with a treponemal test positive, those are still counted as a congenital syphilis case if it meets all the criteria.
Yes, thank you.
You're welcome. Let me scroll down. I know there's more questions. We have some more Q&A. I'm right now in the chat. Okay, Leah, this is for you. In evaluating for reinfection, prior labs may have been done at different EMR or health department. Are lab results from different sites generally equivalent or comparable, i.e. if we were trying to determine if the rise was a 4 titer? Or Dr. Zucker could answer this one as well.
Yeah, so definitely common to have clients that are being seen within several different healthcare systems. If you can always reach out to us here at the state, either myself or our main line, which we can post in the chat too, and we are able to do a record search for you. So we can go through the client's entire titer history with you from any and all labs and health systems. So they are equal, like they are comparable if you're comparing an RPR to an RPR. If it's a VDRL to an RPR, there is a difference there, but RPR seems to be the most frequent non-treponemal test that I see. It's pretty rare actually that I really feel like I see a lot VDRLs, but so if there's an RPR to an RPR, it's an apples to apples comparison, no matter the lab.
Thank you, Aaliyah. Although we do know that there may be some laboratory differences, but it's not enough to make us determine any titer, anything with titers based on that, unless obviously it's a 4-fold increase.
Yep.
And that's actually one of the reasons for the 4-fold increase is it gives you a little bit of leeway since it is a manually done test in many cases. It gives you a little bit of leeway for operator differences, I guess I would say.
Thank you, Dr. Zucker. This next This next question is, Leah, let me know if you want me to answer it. What is the current situation with the bicillin shortage? I'm assuming in Michigan is the question. Is there any updated information on that?
Yeah, Karen, I think you might have better, maybe more up-to-date information than I have in any of the managers' meetings, but so I'll let you if you have a better answer than I might.
The recommendation still stands. Our bicillin shortage is not dire, but we still have the recommendations in place so that it doesn't get dire, and so that bicillin can still be reserved for pregnant women and infants. But I have the actual recommendations here. Let me pull this up. I had it up and then I touched on it and I don't have it, but it is, that's what you get when you're trying to work with your phone. There we go. So the recommendations are: pregnant persons, females of childbearing age, and symptomatic males should be treated with the CDC recommended dose regimen of penicillin G, the bicillin, based on their syphilis diagnosis. Clients with a tetracycline allergy should be treated with the CDC recommended dose regimen of bicillin. Consider treating asymptomatic males with the alternate regimen of doxy as clinically indicated. Treat all syphilis contacts who are not pregnant or who do not have a tetracycline allergy with doxy. So that's 100 milligrams orally, 2 times a day for 14 days. And what is important to note is treat based on stage. Although Dr. Zucker mentioned that adding additional bicillin injection can be warranted for pregnant females, but those that aren't pregnant, please treat by stage, because then that kind of saves it for pregnancy. Dr. Zucker, would you like to add anything?
No, I will add that they've updated the shortage information on the FDA website. You know, they were saying first quarter 2024. Now they're saying end of 2024, early 2025. And that the FDA has recently used their enforcement discretion to allow essentially importation of an equivalent drug from Europe. And when Gowrie sends out the slide, she can also send some information on how you'd acquire that drug as well. It's essentially the same drug, it's just manufactured there. And they're allowing it to be imported now, and they have a mechanism for you to get it. So if you're running low and need drug, there is another option now.
Yes, extensiline.
I can't pronounce it, so I try to avoid saying it at all costs.
All the local health departments should have received notice of the extensiline, I think I'm pronouncing it correct, on how to acquire it. Thank you, Dr. Zucker. Yeah. That is all the questions. If anybody has any other questions, they can come off of mute or add it to the Q&A. Okay, well, doesn't look like we have any more questions. Gowrie, would you like to close this out?
Sure. Thank you so much, Karen. And thank you so much, Jason and Aaliyah, for presenting today. As Karen said, we will send out the extensiline announcement from CDC, as well as the slides and instructions for CE. But thank you so much for joining us today, and we look forward to seeing you at a future webinar. Thank you.